So let's move on now to some of your questions. And we have some interesting questions here, which I have on my iPad. And the first question is, if your patient is not adherent to growth hormone injections and does not want to change, how do you proceed? So this is clearly a difficult issue. I might ask John if you could briefly discuss the approach to a family like that. The child is clearly not adherent, but says, I'm all right. The family says everything is okay. What would you do in that situation?
I think I'll give you a little bit of an answer, and I think some of my colleagues could also add something very usefully. The obvious thing really is to really explore they understand, that position and the implications of taking that position. Do they really know, from the growth charts where that child's going to end up, and are they okay with that? If they're genuinely okay with that, I think probably there's relatively little one can do. If they really understand the condition, the treatment and so on, that's where they want to go. That's the patient's choice.
Yes.
But there may be other issues lurking below the surface, and I think then it's really important to discuss those, maybe real concerns or worries or misunderstandings and so on. And I think, Chris, some of the things I'm sure that Chris has seen can address that.
So really, can I just say, really it comes down to the family and the child, if possible, understanding the basic diagnosis and the basic need for treatment and how they can benefit eventually from that treatment. Okay, now I have a lot of questions, so we need to move on. And the second question is really particularly appropriate. How can I use motivational interviewing if I only have 10 minutes for the whole appointment? I think the answer is that you can't. And I'm very sensitive to the fact that, as I teach in different places, that consultation times are becoming more and more restricted. So basically, it is not possible to deliver motivational interviewing in 10 minutes. I would suggest what you need to do is some degree of reorganization. Now, I know you have 20, 30, sometimes 40 patients to see in an outpatient session. The question is to somehow identify which of the patients are not adhering, which of the patients are not growing optimally, and concentrate on spending a little bit more time with those patients. Because not all the patients will need motivational interviewing. Do you agree?
Yes, I do.
Briefly?
I do agree, because I think it's something that you can just lean into when you kind of get a little bit stuck yourself and you want to be curious with somebody about what's going on for them, and you have just a couple of minutes to do that. Some of my best breakthroughs are just leaning into it. I don't use it all the time, just leaning into it in that moment. Just to build that relationship and be curious about what the thinking is of this person. And asking those open questions can be so revealing, because what pops out will really surprise you as to what the barriers might be.
Okay, thank you very much. So there's another question here, and I'll ask Jenny and Rachel if they can address this. How can you help when the child and their parents have opposing ideas of how much they want growth hormone treatment for the child? Disagreement within the family. How do you proceed?
I think the key thing is to try and connect families together with other families, and to, as far as possible, discuss as many different experiences and outcomes. Ideally face-to-face. The annual convention that we have is a wonderful opportunity to speak firsthand to other parents who have probably gone through very similar situations and come out the other side. Even some acknowledgement of it just being a really difficult phase, and just reassurance that it will pass, and it can be shorter. Just through having that reassurance, then it no longer becomes a long-term issue. Picking up the phone, talking to those like yourself,
yes,
Jenny.
Yeah. Talking to other parents, the support group is definitely would help these conflicting families. They might not always get the right answers, but by talking to other parents, other people that have gone through it, meeting face to face, then it can really make a massive difference to everybody.
Thank you. Chris, have you had families where there's been disagreement within the family?
Have I had family disagreements? Yes, massively. And I think that everybody's trying to protect everybody else. So the family don't really want to be saying he's playing up or she's playing up. The child just doesn't want it, and the health professional is trying to gauge between the two. So lots of conflict, and I think, as you said, it's support from others as well, to know that they're not the only one who's gone through this, and they're not going to be the only one in the future. This is commonplace. This conflict is commonplace.
Perhaps the child that's in, the child is fine to take the treatment, but the parent is the one who's having qualms. Yeah. Again, they can have reassurance about how to best deal with their own issues that they have with their child needing. We have got some parents and families where perhaps the mother is fine with the treatment, but the father feels differently. And obviously, if they can manage to speak to other families in that situation, it enables them, equips them with the tools to kind of overcome their own issues and their own barriers.
And also to see other children much further on in treatment. You know, they may have had treatment for the last 10 years or so, and to actually see the difference that the treatment can make would help greatly.
Thank you very much. Okay, so there's another question from a mother. My child will be 3 in July. He has been diagnosed with Russell-Silver syndrome. We were with the endocrinology team last June, and I'm going back next month. So far, he is following our growth pattern, going back now to see how he has grown. What questions would the mother have, what appropriate questions would the mother have for the team? So maybe as a pediatric endocrinologist, I can just think about this. Essentially, children with Silver-Russell syndrome often do not have good catch-up growth after birth. And they are a group of children who need following carefully, because potentially their height can deviate from the normal centile lines. So I think my advice to you would be to make sure that the child is accurately measured in the endocrinology center and accurately plotted on the chart, and that it would be appropriate for you to become concerned if there is evidence that the child's height is deviating from the normal centile lines. And that would be the time to start discussion of possible growth hormone treatment at some point. If the child is growing parallel to the centile lines, that is a good sign, and I would say in that situation growth hormone treatment would probably not be indicated. So let me see what other questions we have. Can children and their families benefit from referral to psychological support or counselling? John.
Well, the short answer is yes, particularly in some of the situations we've heard about, where there may be conflicts within the family, perhaps serious resistance from the child, needle phobias, all the things which have clear implications for psychological support. So the short answer is yes, but obviously it depends on where you are. In some hospitals there is very good support and very good referral available for those issues, but there is certainly a lot of expertise out there. But my sense is that the specialist paediatric nurse can often provide that support too.
Yes.
And I think I think there's a danger in jumping into psychological referral too early, because people can get a little bit pathologized and feel a bit stigmatized by that.
Right. So do you think that a key point is for the healthcare professional, either the doctor or the nurse, to be able to recognize those psychological issues that are too complicated for them to deal with, and that would be an indication for referral?
Correct. Yeah. I think that's the key issue.
Yes.
And
I was just, yes, because we do get involved a lot, because not everybody, and we certainly don't have a psychologist attached to the team. And these issues are ongoing, but what we do is we meet with the psychologist quite regularly, not attached to the team, but the psychologist for Child Health, and we discuss patients so they can give us strategies. They can Because we're always worried as nurse specialists, we're not psychologists, that we're going to say the wrong thing. That by saying a certain thing, we're going to make things worse. And I'm sure that you as parents have felt that as well. You don't want to do the wrong thing. So if you don't have a psychology service, I would say try and access a psychologist to discuss specific cases regularly so they can give you guidelines on how to approach the parents or approach the child.
And this really comes down to having a multidisciplinary team really working for the optimal response to treatment in these patients. Let me ask Jenny and Rachel, if a mother phones up and over the phone you get a sense of true psychological abnormality, would you recommend to them that they seek the advice of a psychologist?
Depending on the actual phone call, yes. If it's sort of just general, my child doesn't want his injection, it's stressful, it's causing all sorts of problems, then it would be a case of, well, why don't you talk to other parents who are going through that? But yes, if there is a real problem, which sometimes there is, and sometimes it does need to be referred on to a psychologist, so we would say see your endocrinologist, and hopefully they can point you in the right direction to the correct support, because it certainly is something that we're seeing more and more of, especially as the child gets older, through adolescence, etc. They do seem to be, finding it quite difficult to get through. So certainly support in some cases is a definite.
So I want to come back to motivational interviewing, because this seems to me a really new aspect to many of us of the management of growth disorders. And the fact that the healthcare professional, whether it's a doctor or a nurse, needs training. I think this is important. Katie, have you noticed any resistance from either doctors or nurses in accepting the fact that they need to be trained in some situations?
I haven't experienced that resistance with healthcare professionals. I've experienced a genuine interest, and that this could be a tool in the toolkit that they can bring out. I just want to say that I'm not a psychologist either, and I'm aware that I'm using something that is a behavioural change tool. And I think it's about going into it, easing into it gently. I just started with the principles. Then I started to play with the skills. There's no danger in doing that. And then I started to read and understand and do courses and do training. And then I wanted some supervision. And I think it's just dipping into it and seeing how it is for you.
Thank you very much. I think one key message is that if adherence is going to be addressed effectively, it does take time. And of course, we all have time constraints. And in some parts of the world, there are so many patients that need to be seen that the time for a consultation may be 5 minutes or something like that. But if we are going to improve growth responses, we need to recognize that adherence is a key problem. It's very easy simply to fail to admit that some of our patients may not be optimally adherent. And I think many of us have done that in the past. I certainly have. But now this is very much part of new management, a new approach to management, linking e-health tools with a personal human approach. And I think that is how we can progress in a very, very positive way.